Welcome to Forums That Matter, a community service of the Unitarian Universalist Congregation of Cleveland. I'm Jim Boyle, a member of the Forum Committee, and I'll be the coordinator for today's discussion, which has both remote and in-person audiences. Our topic today is healthcare redlining. This is a topic that's especially meaningful to me. I've worked at St. Luke's Hospital and St. Vincent Charity Hospital, which are two of the 8 hospitals in Cuyahoga County that have closed in the last 15 years. Others include Mount Sinai, St. Alexis, Deaconess, Richmond General, Bedford Community Hospital, Huron Road Hospital. And all of these hospitals have in common that they served under-resourced communities with significant Black populations. So in a sense, since I've been through 2 of the hospital closures, I have a feeling personally for what it means for the employees and to some extent for the patients who have been coming to those hospitals for care. We'll have our speaker from 9 to 9:30, and then we'll have questions from the audience from 9:35 till 10 o'clock. And Debbie will coordinate the questions. Be sure your phones are off or in airplane mode. This program is recorded and will be available in a few days on our website at uucleveland.org. It's my pleasure to introduce our speaker this morning, Dr. Sadeer Al-Kindi. He is a co-director of the Center for Integrated and Novel Approaches in Vascular and Metabolic Diseases at University Hospitals. He's an associate professor of medicine at Case Western Reserve University School of Medicine. He has expertise in cardiac imaging, heart failure, and preventive cardiology. He's the author of a recent paper in the American Journal of Cardiology on the long-term impact of redlining, which was instituted in the 1930s by banks for home loans and other business loans in areas of the community that were designated as high risk. His paper showed that this had significant long-term health impact in the people living in redlined zones. So at this point, I'm going to ask Dr. Al-Kindi to take it from here.
Thank you so much for the invitation, and it's really a pleasure to be able to talk to you today about this important topic. As Jim mentioned, I am a cardiologist by training, and I'm practicing at university hospitals. But I also, do quite a bit of research, especially community-based research that kind of reduces the gap in treatment of cardiovascular disease as it relates to my specialty. So today we'll talk a little bit about redlining and cardiovascular health, but in reality, you can really apply this to any type of health outcomes. I just picked cardiovascular disease because it's my specialty, but it's also the #1 killer in the United States, but worldwide as well. I have no disclosures related to this topic, but we'll start by talking about what redlining is and what are the kind of history of redlining. And redlining is basically it's an unethical practice that was designed back in the 1930s in the United States, because it puts services, financial and otherwise, for out of reach for specific residents, for under-resourced residents, people from specific ethnic or racial minority. And it's a type of systemic racism, right? So you see that it's a denial of mortgages. That's how it started, but we'll show you, hopefully will convince you throughout this talk that it does a bit more than that, a lot more than that actually. So initially started as a denial of mortgages, denial of insurance and loans and other financial services based on specific location, but that location has been tightly wound with the racial composition, the ethnic composition of individuals, which made it even more complicated. So in the 1930s, there was a creation of an entity called Homeowners Loan Corporation, or HOLC for short. And this is a federal sanctioned kind of entity that led to because of the dramatic increase in home loan and mortgages. There was the Great Depression at the time. So they said, okay, we're going to make new kind of policies to identify areas that are likely versus less likely to pay mortgages back, and identify the mortgage risk by areas. So between the 30s and in the mid 30s, they issued about 1 million home loans at that time. And then in 1935, they said, let's do a risk assessment of all the loans in the United States and identify, the risk of the area. What is the likelihood that you're going to pay your mortgage, and so on and so forth. So of course, that created a series of maps. At the time, it was about 200 cities in the United States. Most of them are urban cities. And they really color-coded them. They used 4 colors, red, green, blue, and yellow. And we'll show you a couple of these maps in a second, but they rank them from the top, highest risk to the lowest risk. And obviously that led to, the HLC examiners to systematically utilize these maps to decide whether to give loans or no. So the criteria that were used to color code these maps was the aging condition of the housing in that territory or neighborhood, transportation access, closeness to parks and pollution, and so on and so forth, and then economic class and ethnic and racial composition, which really played a significant role in identifying these maps. So in the 1934, this was actually the Federal Housing Administration and that was established by Roosevelt in the 1934 set these standards for loan repayment and loan giving to individuals. But because of these maps, this led to systematic racial disparities with respect to providing loans versus not providing loans, right? So that led to capitals, restriction of capital to people of color, for example, racial minorities, and led to a whole lot of problems that we'll talk about in a second. So the term redlining actually come from the fact, this at the time was not called redlining. This term was coined a little bit later with respect to these practices, but it was coined in the 1960s and literally referred to how these lenders used red lines to deny mortgages to individuals from specific areas and specific neighborhoods. And back in the day, there was no legal obstacles to lending discrimination, so they could decide who to give on individual basis, and these maps serve to propagate the racism that happened at the time. So the history of redlining, like we talked about, banks would not give capital to individuals who live in these areas or want to buy houses in these areas. And then there was a vicious cycle of these neighborhoods, because now you have decline of economy in these neighborhoods, and then you also have inability to access capital, and that led to propagation of these differences. And even before 1968, which was the Fair Housing Act, there was really no obligation for lenders to provide equitable mortgage loans. So this led to a few things. People were stuck because even if you have money, they couldn't really access capital, right? So you could have down payment for a house, but really you can't get a mortgage. And then homeowners in other areas were prohibited to selling and buying homes in the areas of where there's a lot of people of color and immigrants. And then this led to discriminatory practices that propagated over the years led to isolated minority communities, reduced housing, and caused a lot of problems, including poverty. So, of course, in the 1968, we got the Fair Housing Act of 1968, which was signed by President Johnson, and that really attempted to mitigate the negative impacts of redlining, because now everybody has eliminated discriminatory practices, or at least attempted to, and it was illegal now to withhold mortgages and capital from individuals based on their color or race. This was a nice, so this is fast forward to now. This is a nice article in the Washington Post that was published a couple of years ago. And really the title was Being Black Lowers the Value of My Home. And really, if you think about the same home, which has the same kind of characteristics, if you if that house is in a Black neighborhood, then you get a much lower cost or price of that house. So this led to also issues with kind of wealth discrepancy that was a big issue that relates to healthcare, which we'll talk about in a second. So now we were interested in, being a physician and a cardiologist, I was really interested to understand to what degree does redlining really is associated with present day cardiovascular health, right? So these are some of the maps you can see on the left upper corner. These are some of the original maps that were since then kind of recovered and digitized, and now we can overlay them with maps of the United States in specific neighborhoods. And you can see on this map, you can see different colors. The red, again, is the highest risk, and the green is the lowest risk. And in this case, this was Los Angeles, but you see maps of Cleveland, you see maps of every major city. So our hypothesis when we wanted to study this is really, we know that there is redlining in the 1930s. We know that this led to capital and multiple disinvestments in these neighborhoods. But we also think that there may be some differential environmental exposures. So for example, air pollution in these areas could be higher, right? So socioeconomic stressors. So potentially people have less access to capital that led to reduction in wealth over time and intergenerational changes in their income. And then also there is racial segregation, there is discrimination, there is systemic racism, lack of access to healthcare, which is important, and then unhealthy lifestyles, which were really kind of impacted by all of the above. So what we did is we took these maps that were generated in the 1930s and overlaid them with the current present day, what we call census tracts, which are small neighborhood boundaries. And you can see here on the left lower corner, you can see that there is multiple cities, more than 11,000 neighborhoods that we examined. And we categorize these neighborhoods based on the 1930 categorization into green, which is best, still desirable is blue, and then yellow is declining and hazardous. And we wanted to look into a couple of things. One is we wanted to look into cardiovascular risk factors, so diabetes, high blood pressure, high cholesterol, and so on and so forth. But we also wanted to see if these areas have higher risk of coronary disease or stroke or kidney disease. And these are important determinants of mortality and longevity. So this is a map of Cleveland. You recognize Lake Erie and then downtown Cleveland. And Cleveland, like the seasons we experience, has one of the most segregated neighborhoods, right? So you see all four colors, which is not usual. If you see other cities, some of them have mainly green, mainly blue, mainly red, but we really have all this, the entire spectrum. So, and you recognize that the inner city, for example, mostly is redlined, while the suburbs are a little bit less redlined, although you see some suburbs that have significant redlining, especially in East and West Cleveland. So lo and behold, when we look into risk factors, and these are the four major risk factors: diabetes, smoking, obesity, and blood pressure, elevated blood pressure. These, you can see that there is a significant association. So if you look at the green, for example, for diabetes, people who live in the green neighborhoods, they have 9%, proportion of the patients, or what we call prevalence of diabetes. If you move to a red-lined neighborhood, then that goes up to 13.5%. And the same thing applies in smoking, applies to obesity and high blood pressure. And it's not so much that we didn't expect this, but what shocked me, honestly, is the degree of that relationship, right? I would have expected maybe 2%, 3% difference, but here we are looking at a relative difference of about between 30 and 40%, right? So if you compare 13.5 and 9.5, that is about a third higher, which is dramatic. And there is what we call a dose-response relationship, meaning that as we increase the risk of the color from green to red, there is a clear increase in any of most of these cardiovascular health outcomes. The second thing we wanted to look at is the disease itself, right? So these are what we call risk factors, although some of them are also diseases like diabetes and other things. But what leads to significant reduction in longevity and length of life is the presence of actual disease. And this is really kind of advanced stages. And coronary disease is one, stroke is another one, and chronic kidney disease, which is a major determinant of health. And you can see to the same degree, you see that the same thing here happens, right? You have approximately between 20 and 30% increase, relative increase between the green neighborhoods and the red neighborhoods. And that goes across the board. And again, remind you, this is about 11,000 neighborhoods in the United States. So if we went back to the same map that I showed you, which is the Cleveland map, this is the HOLC, so green, red, blue, and red, yellow and red. And then, but we wanted to see what is the disease state and what is the distribution of disease. So we just color coded the diseases, the prevalence or the proportion of diseases using the same colors. So you see that these maps are almost, indistinguishable between each other, because what happens is the same neighborhood that has redlining on the left upper corner is also the same neighborhood for the most part that has higher risk of coronary disease, higher risk of stroke, and higher risk of chronic kidney disease, right? So you can see that now then there's geographic relationships between these topics. And what's striking is that in areas that are neighborhoods that are adjacent to each other, right? That go from, like in this case here, I don't know if you can see the box here. In this case, for example, you can see a neighborhood that's red, and then adjacent neighborhood is green. And for all of us who live in Cleveland, we know that this is existing even at the house pricing level, but on different levels from one street to another, you see stark differences. So this was really a major issue, because we were the first people to show that redlining is linked to heart disease, and this was picked up by major kind of publication. So for example, this on the left side is The Hill, which is the Congress kind of newspaper. And that picked up the study saying that historic redlining is linked to present day cardiovascular health or heart disease risks. And this is on the right side, you recognize the Plain Dealer, which also generated some maps and stuff like that. So for those of you who want to read more about this is, I think in the July or August issue of Redlining. So I also have a major interest in environmental health, meaning I want to understand really what is the contributor to cardiovascular health outside what we talk about. If I have a patient in front of me, I usually talk about diabetes risk and high blood pressure risk when I see them in clinic. But really, what are the major kind of origins of these things? And we realize that a lot of the origins of risk factors and disease is not something that we only do ourselves, like lifestyle, but a lot of it is the environment that we live in. So one of my focuses, one of my foci of research is really understanding how does the environment that you live in, that's something that we don't think about often, right? So what is light, how much light you have, how much light pollution do you have? What type of energy do you use, whether it's electric cars versus regular cars? How many highways are near your house? And how much air pollution and temperature? All of that stuff is really what I want to understand. So I wanted to understand, why does redlining, we know that redlining is linked with heart disease, but how does that happen? And are there parts of the environment that happened, the environmental changes that happened in redlined areas versus non-redlined areas that really drive some of this risk? So we took these maps again, and we overlaid them with a wide spectrum or wide broad spectrum of variety of environmental exposures. All of these environmental exposures that you see on the screen, which I'll talk about in a second, have been linked with heart disease in other studies. So now we want to see, do people who live in redlined areas have higher rates of air pollution, for example? Do they have higher rates of toxic water, and so on and so forth? And you've heard about Flint, for example, in Michigan. So, and Flint is major redlined area. So let's talk about what this means. So now on the X, on these figures show you that the color-coded HOLC grade, which is the redlining grade, same colors that we saw before. And now we talk about proximity to traffic, right? We know that the closer you are to a highway, the higher the risk of heart disease, the higher risk of stroke. So you can see that across the board now we talk about wastewater discharge, we talk about toxic air with the lung, kind of that impacts lung, the toxic air that impacts cancer risk, diesel air pollution, which is from diesel cars, and the proximity to national priority lists. There are some priority lists that the US generates that are factories, for example, that emit a lot of air pollution. So we wanted to see to what degree, and so on and so forth. We want to see to what degree do these relate to redlined neighborhoods. And you can see across the board, there is a higher exposure, maybe with one exception, but there is higher exposure, higher risk, environmental risk for the redlined areas compared with green. And in some degrees, this is really significantly higher, right? So we talk about sometimes doubling, sometimes third higher, fourth higher, and so on and so forth. So there is significant increase. The other thing that is also something that we don't think about as often is what is the proximity to green space, right? So if you have a park next to you and you have higher likelihood that you can walk in that park or do healthy exercise, but it also can reduce the temperature around you in cases where you have high temperature. It can also help you clean the air around you and reduce your air pollution. And you can see in this graph that people who live in redlined neighborhoods have significantly lower access to green space in parks, higher rates of noise, and that is expected because now we're living closer to highways, but also higher light pollution, and that by itself also has been linked with cardiovascular disease. And this is light at night when the city goes to sleep. If you have a lot of light that is not turned off, this can be mapped throughout the United States. So this led us to think a little bit more creatively about, okay, how do we really investigate kind of the linkages? Because without knowing what is causing heart disease in redlined neighborhood, we cannot fix it. So we'll talk a little bit about how we are starting to think, at least from the research standpoint, how to implement and things to try to fix this gap, reduce that gap, and improve cardiovascular health. Now, the other thing that we looked at is longitudinally over time. So has the air pollution changed, for example, over time in these areas? And this curve shows you that there is really no big differences in areas with redlined, and they still have excess of air pollution, no matter how you look at it. And I don't want to be technical, but NO2 and PM2.5, these are two different air pollutants that have been linked with heart disease specifically. And you can see that areas that are in redline, they have approximately 30-40% higher risk of exposure to these pollutants. And this hasn't changed from 2005 till now. The same thing in PM2.5, which is one of the other major pollutants. And this has not changed significantly, maybe a little bit of reduction, but we can see that people who live in areas that have higher pollution, they have, who live in the red line areas, they have higher pollution, approximately 5 to 6%. So how did this impact, and how was this impacted in the era of COVID-19? We know when COVID pandemic hit, we started having a lot of closure, not necessarily of hospitals, but of services. And one of the major things that got hit was cardiovascular services. So if you wanted to get a stress test, for example, or you get a heart catheterization, you were not able, especially early on in the era of COVID. But that we felt that this, at least from the observation standpoint, we felt that this impacted people of color more so than impacting people of the general population. But also we found that because there is reduction in transportation, there's a lot of things that happen. People who are more vulnerable, communities that are more vulnerable, perhaps had higher risk. At least that's the hypothesis, or we started to notice that on daily basis. And we wanted to study this a little bit more systematically. So the first thing we wanted to do is, we know that COVID led to increase in heart disease, death from heart disease, and all-cause death in general in the United States. And we wanted to see if the degree of excess death or increase in death between pre-pandemic to post-pandemic was related to social vulnerability or measures of socioeconomic status. So what we did is we took the entire United States and we looked at every single county in the United States, and we compared the death from all causes between pre-pandemic. In this case, we chose 2019, which was pre-pandemic, and 2020 and 2021. So we wanted to study early post-pandemic, which is 2020, and then a little bit later post-pandemic in 2021. And we divided counties into high socioeconomic status, which is Q4 here, versus low socioeconomic status in Q1. And this is metric called Social Vulnerability Index, which is coming from the CDC, Centers for Disease Control. And it is a measure of how prosperous the county is. And this is determined mainly by income, but there's a lot of other social factors that enter into this measurement. And we see that in 2020, the excess death, there's about 20% higher number of deaths compared with 2019. But that risk is not uniform. You can see in people who are, counties that are somewhat rich, higher socioeconomic position, they have 20%, but in counties that are lower socioeconomic position in violet color and purple, you can see that these have a much higher mortality, excess mortality. The same thing applies now in 2021. Mortality, the excess mortality came down because now we've realized that there's vaccines, the hospital services started opening up again, but now we start seeing that the risk is also the same in terms of the relationship between social vulnerability of the county and cardiovascular disease. On the right side, you see excess cardiovascular mortality, death from heart disease or vascular disease. And you can see at baseline, it's a much higher risk, right? So you see 30% here compared with 20% for all-cause mortality, just because COVID impacted people who have heart disease much more, but also led to the closures of services that are related to heart disease. And you can see that there's a relationship, significant relationship again, that we notice between social vulnerability index and cardiovascular mortality. That's excess compared with 2019. The other thing that we wanted to look at is what is excess? Is that excess cardiovascular mortality? Is it different by race? Do people who live in areas that are socially vulnerable, are Black people, for example, Black patients who have cardiovascular disease at higher risk compared with white patients? And if you look at excess mortality, and in this case, we took 2018, so even further back as our baseline, and we started to look in 2019, 2020, 2020. And if you look at the excess cardiovascular mortality, you see that in 2019, nothing happened. It was just 0.7%, so there's really no difference between 2018 and 2019. When we look in 2020, this is where COVID hit, we have 7% excess death, percentage of excess death. And in 2021, there is 7% excess death. This is in the general population, everybody throughout the United States. But what was striking is if we start teasing out the race of the individuals who died or descendants, you see that in 2019, there is really no big difference, 0.7%, 1.5% between Black and white, Black and blue here, and white and orange color. You can see that there is really a small difference between between Black and white in 2019. But what happened in 2020 really propagated that difference, right? You can see that the excess mortality among Black individuals in the United States was about 16% in 2020, and it was about 5% among white individuals. And in 2021, the risk was very similar. So we see now, we start to tease out some stark differences, about threefold difference in excess cardiovascular mortality that happened post-pandemic, suggesting that the pandemic hit minority populations to a much higher degree, especially those who have pre-existing cardiovascular disease, because it led to a significant increase in cardiovascular mortality. So indeed, if you want to read about this, there's a little link here, but indeed what we found is that the study showed that this pandemic, which happened in 2020, erased about 20 years. We've known for a long time that there is disparities between Black individuals and white individuals with respect to cardiovascular disease. In all the years, it's been, Black individuals have higher risk of heart disease and heart death for a variety of different reasons. But we've been closing that gap over the years. So every year that gets closer and closer between white and black until the COVID hit. And when COVID hit, it erased about 20 years of that work that has been done to actually decrease the disparity or the gap between cardiovascular death. So this is, stark differences that we found through analysis. Now, what are we actually doing to start to help and to erase all of this stuff and improve the disparity? So the National Institute of Health, NIH, has funded large projects that are focused on really reducing this disparity and reducing that risk. And this is called the Health Equity Action Network. And the idea is to really focus on multiple diseases, whether it's heart disease, whether it's asthma, whether respiratory disease, to reduce the disparities between Black and white individuals, but also to reduce disparities across the nation. So they funded multiple centers, as you can see here. Some of the centers, one of the centers that we got lucky to got funded is Case Western and University Hospitals, and we joined forces with Detroit, Michigan, because we share the same kind of disparities. Detroit and Cleveland have one of the worst gaps between Black and white individuals with respect to length of life, but also with respect to cardiovascular disease. So they funded 11 regional centers, and we're lucky to be part of them. And our project is a community-based intervention that aims to do a few things. And we wanted to look at the trajectory. So if you look at the trajectory of health in childhood, early adulthood, middle age, and advanced age, and elderly, and then you can see that people move from healthy to elevated blood pressure sometimes to organ damage like chronic kidney disease and other things, and then they lead to heart disease at the end, which leads to loss of life. So we wanted to interject this trajectory and focus on how do we move this trajectory from going to here through multiple kind of across the spectrum of age, across the spectrum of disease to impact the life course. So we have 3 projects. One project is designed mainly in Detroit to look at hypertension, high blood pressure, and how to intervene using mobile health units. So we deploy kind of cars to different communities, measure blood pressure in individuals, give them medications, and so on and so forth. Project 2 is focused also in Detroit from Henry Ford Hospital that focuses on congestive heart failure, how to screen communities for congestive heart failure and identify. And our project here in Cleveland is designed to interject on coronary heart disease risk or plaques in the heart, plaque in the coronary artery. And by intervening on the risk factors, comprehensive risk factor reduction, meaning blood pressure, how do we identify blood pressure in the community? How do we reduce cholesterol in the community? And how do we reduce sugar levels in the community? And we have partnered with Cuyahoga Metropolitan Housing Authority. So this is a busy graph, and I'm not going to go through it all completely, but the gist of it is we are partnering with Cuyahoga Metropolitan Housing Authority, and the idea is we are going right now and do a screening fair in these public housing programs, which are one of the largest in the country. And we screen individuals, primarily Black individuals, middle-aged individuals, screen them for blood pressure, and we identify individuals who have high blood pressure that they are not aware of, screen them for their blood sugar, identify people who have diabetes or pre-diabetes, we identify smoking patterns, and we look at their cholesterol and we measure their weight. And we put them through an intervention pathway to really try to fix medical issues, like, if the blood pressure is high, we give them medications. But more importantly, I think, is intervening on the social risk, right? So a lot of people have what we call social determinants of health. Like, I can prescribe all the medications I want, but if you don't have healthy food, that's not going to work. And if you have no transportation to go pick up the medications from pharmacy, that's not going to help. So there are a lot of resources, but the problem is a lot of these individuals, they don't have the capacity to get linked to the resources because usually there's obstacles. So what we do is we identify their needs in the community. For example, if an individual doesn't have healthy food, we hook them up and connect them with food banks. If they don't have transportations, there's a lot of county and federal kind of resources for providing transportation to medical appointments and so on and so forth. And then at the end of 1 year, we also do a variety of different kind of metrics using, we give them monitors. We were talking just now about monitors, for individuals. We give them blood pressure monitor and so on and so forth, and we are able to measure their blood pressure on daily basis, sugar levels, and so on and so forth, with the hope that we can improve the risk factors, with the hope that we decrease the risk of heart disease. And I'm going to just stop here for, yeah. Thank you so much.
Thank you, Dr. Al-Kindi. You've given us a lot to think about and very informative. So I'd like to open up now to questions and answers, and Debbie will handle the microphone for the audience here. And for those who are watching us online, if you put your questions in the Q&A box at the bottom of your screen, we'll get to those. So Debbie, take it away.
Well, since no one's raising their hand, I'll ask a question. The question is about choices of which hospitals get closed down. You know, we looks to me from an outsider point of view that we're closing the hospitals down in the poor neighborhoods, and the neighborhoods where people don't have access to public transportation, where they could actually walk to the clinic instead of take a bus across town to Abuja or someplace like that. This is not your area of expertise, I realize that. But isn't that something that as a society we should think about, like where we close the hospitals?
Yeah, I absolutely. I think there needs to be some planning, right? In terms of, first of all, hospital closure is not good anywhere, right? I mean, we always have shortage. If you go and you want to sign up for an appointment right now, there's waiting. And Cleveland has probably one of the highest densities for hospitals in the country, but still there's a long waiting line. So, you know, we always as physicians advocate for improved access. But I think it's also important to realize that although physical access is one thing, but there's a lot of, you know, access that is not measured, right? So a lot of people have, you know, a hospital across the street from them, but these individuals have one of the worst kind of disease conditions that just because you have hospital next to you that could be a branded hospital, one of the top in the country, just you can't access that hospital, whether the insurance, lack of insurance, lack of coverage by the hospital, you know, or just having other issues that you cannot even leave the house for, or, you know, lack of childcare that can take care of your kids when you go and visit. So there's a lot of complexities, I think, to this, and, you know, it's beyond my expertise to define where things are, but maybe Jim has some insights into you know, why hospital closures happened. We're going through one of the worst financial crises for healthcare in decades, unfortunately.
Obviously, it's capitalism, but anyway.
Thank you for your talk. It's really interesting. So your data is looking at the redlining from the 1930s, and that's showing a really powerful connection to modern outcomes. I'm curious if there are examples of specific communities that have flipped from 30s to now with the demographic shifts and the socioeconomic status, where in the 30s maybe it was a red line and now it's considered, you know, an affluent community, or vice versa. And if you can show any differences in outcomes during that period of time.
Right. No, that's an excellent question. And I get asked every time I give a talk about redlining this specific question. So the problem is that redlining is fixed, right? Technically, it's basically you have redline versus not redline, because now we cannot reclassify, you know, there's no criteria. All these criteria was somewhat subjective, right? We don't have the same criteria that we can calculate whether a neighborhood is redlined right now or not. And in general, most redlined neighborhoods have remained impoverished, right? So there's really very few examples of how neighborhoods flipped, like you said. And in these neighborhoods, you see a reduction in cardiovascular disease. You see less, it's almost equivalent to the originally green line. So it tells me, it gives me hope that, you know, we can do some interventions on these neighborhoods that can actually impact how these neighborhoods thrive over time. But it requires a lot of investment, right? It requires a lot of resources. And I can give you a couple examples of in Houston, in downtown Houston in Texas, they had most of the neighborhoods were redlined. And they had really no green space, not like what we have here. Houston is a little bit more, you know, kind of deserty, so to speak. So what they did is the city invested, and they have a lot of risk of heart disease, obesity, and so on and so forth. The city invested in creating a path, a green path, right? So more protected green space that implanted a lot of trees, and then they put connected a lot of small kind of parks together And it just so happens that these parks happen to pass through very impoverished neighborhoods. And the data suggests that one of the studies that we did suggests that there is a actual reduction in obesity and after the production and connection of these green pathways. They're called bio-greenways, and we see that there is a real close connection between planting trees and so on and so forth with the reduction in obesity in that neighborhood. But again, I think there is a lot of literature to suggest that if you intervene on the community, if you plant trees, for example, if you improve economic connectedness of the individuals, meaning that if you provide them with mentorship, especially for young individuals who live in these impoverished neighborhoods, you can actually change the trajectory of wealth, change the trajectory of health, and hopefully that will happen in the future. But we need to identify the critical kind of interventions that are needed to actually improve the trajectories, as opposed to putting a lot of money into something that we don't know whether it will work or not. So that's really where I think the research, at least from a health standpoint, is going to go to identify the points that link redlining with health outcomes.
There are a couple of online questions. The first one from Susan is, will this project provide internet accessibility to enable telehealth services? Has there been any work on internet access and healthcare?
Fantastic. No, yeah, that's a great question. And there is actually a lot of literature on digital redlining, right? So these areas that I showed you, they also have no broadband access. There's no internet access for the most part. Interestingly, Cleveland is one of the innovators in this space. There is a consortium called Digital C, or Digital C for Digital Cleveland. And this basically is a consortium, I think, between Case Western and other institutions in Cleveland that aims to address this specific question: is, how do we provide access to neighborhoods that don't have internet access? And without having internet access, we cannot do virtual care. We don't do virtual visits and so on and so forth. So it's critical, and we're working closely with them to really align. And a lot of the CMHA, Cuyahoga Metropolitan Housing Authority, they have a real good connection with Digital C organization that helps provide these at no charge. So the answer is yes.
Another online question is, when Cleveland Clinic closed Huron Hospital, they created the Stephanie Tubbs Jones Health Center in its place, with the goal of improving access to preventive health care. Do we have any data on the impact this has made on health outcomes in that East Cleveland neighborhood?
Yeah, I can't speak specifically to that. I don't know. We don't have data yet. I'm not part of that health system, and it's difficult to. All the data that I showed you is lagging behind approximately 1 to 2 years to know whether there is a real health impact or no. It takes time to analyze the data meticulously, because there's also other things like demographic shift and people getting older over time, and the disease is going to increase over time. It's a given. So the impact of doing one intervention like this, for example, closing hospital, opening something, is going to take time to actually tease out, and I don't know the answer to that question.
Thank you very much for me at least, a very enlightening presentation. So I have a question. Your point, it really doesn't matter where the hospital is located. It can be in a poor neighborhood, but if the residents can't afford to access the hospital, then we have a problem. So with a workforce that's increasingly part-time, and in the private sector, as more and more companies reduce healthcare benefits, what strategies would you suggest that we pursue outside of private insurance so that residents in neighborhoods can afford to go to the state-of-the-art hospital down the street?
Right. Now, that's an excellent question. And I think one of the things is these hospitals that we're talking about, they have to take they take the lead into providing community benefits, right? And I can only speak to what UH is doing. And, UH has invested significant amount of money and resources into providing community benefits. So just one example of that is, as it relates to cardiovascular health, identifying disease in the heart is early on is very important. And screening for heart disease sometimes is important. And oftentimes, if you go to any hospital, you get charged for doing it. For example, a CAT scan of the heart, you get charged $300, $400 across the nation. And this is a test, for example, is not covered for by insurance. A lot of you may have heard about University Hospital's cardiac scoring program, right, or calcium scoring program, which is really done at no charge. You go get the test done, and the hospital invested millions and millions of dollars into providing this program for the community. And as of, I think, last week, we have approximately 100,000 scans that were performed at no charge to identify disease. Because now, if you identify disease, especially early on in the course of life, then you can tailor treatments and screen other additional screening processes. So I think healthcare is in the United States is going through a vicious cycle of costs, right? That leads to people cannot afford it, and then leads to increase in cost because a lot of people are not paying the bills, right? And that leads to a vicious cycle that's going to keep worsening. And I think healthcare organizations have to take the lead into fixing some of this. But we also have to start thinking a little bit as the systems, how to improve and operationalize healthcare to make it cost effective, right? So one of the things that I didn't have a chance to talk about is how can we, you don't necessarily, for example, if you have high blood pressure, you don't necessarily need to see a specialist in high blood pressure. 99.9% of the people can be treated by a general practitioner. And we're realizing that there are care delivery models that are even non-physician related. So there's no significant amount of literature that pharmacists can control your blood pressure, sometimes to a better degree compared to physicians. And now we are deploying, for example, as part of this project, we're deploying community health workers that are very cost effective, and they resonate with the communities that they go in, right? These are individuals who are trained, not necessarily super medically trained, but trained in medical practice to a certain degree. They cannot prescribe, they cannot do certain things, but they can help you take your medications, help you fix the problems to taking the medications, and so on and so forth. And studies have shown that these models are super effective, and these are in low resource settings, like in a lot of countries in Africa and India and Southeast Asia. A lot of these countries are utilizing some of these approaches that really at very minimal cost you can treat populations, as opposed to spending a lot of money into a specific number of individuals.
Another virtual question. I would be interested in seeing an association with redlining and incidents of gun-related violence, homicide, and suicide.
Yeah, thank you very much. I think there is one paper that talked about that and showed clear relationship, and one of our collaborators is really working on this specific thing. It's not just showing that there is a relationship, but at least how does that impact cardiac disease, right, or health outcomes, right? Because one of the things is, yes, gun violence, but with respect to health outcomes, how do you make the connection between redlining and health outcomes, and making that gun violence as a core part of it? And gun violence has been linked with heart disease significantly throughout the United States, and has been, at least in one study, linked with redlining. And some of our collaborators are working on kind of trying to tease out these associations a little bit better.
Thank you for your talk. I'm a professor of neurology at UH. I think just on the broader perspective of what you're talking about, as been mentioned in other questions, the real issue here is support and payment to hospitals. University hospitals and the Cleveland Clinic both lost almost $250 million in 2022 and are making major changes. You don't make money taking care of Medicare and Medicaid patients, and it reduces your costs. You only make money hospitals, that is, taking care of private patients, private health insurance. The system is not going to change until hospitals can be paid for what they do. That's why Mount Sinai went down. That's why St. Alexis went down, St. Luke's, and I strongly suspect Dr. Boyle would tell us that a lot to do with the inner city hospital that went down. One interesting thing to move on to what you're talking about would be the influx of whites into the inner city. Tremont, Ohio State, Ohio City, the apartment complexes on the east side of the river. There's something like 30,000 Caucasians now living in downtown Cleveland, and there's a continued move. It would be interesting to look at that population versus the Black population, because I think this is, this is initial poverty, almost more than race. And trying to educate poor people to take better care of themselves is an important task that we have to do. I run a clinic, a continuity clinic at UH that meets on Wednesday afternoons. Our no-show rate from inner city patients is huge. And yes, transportation is an issue, but there is a health line that drop patients off unusually right from the hospital. So that is an issue as well. RBNC is in trouble because 85% of the patients at RBNC are Medicaid. And these are issues that are not going to change until we change reimbursement to hospitals.
Yeah, I think changing reimbursement is one thing, or making care more cost effective, right? So that's the other way of fixing it.
I know this is maybe out of order, but it's also changed the model of care. Hospitals were run by free religious organizations until the 40s and the 50s. We didn't have health insurance until the 60s and 70s. And your residents used to work for like $10 a month, and now they actually get paid money. So the whole system has changed, and we haven't figured out how to pay for it.
Sure.
Just as an example.
I appreciate all the efforts that you're making in communities. But I'm thinking in terms of the entire healthcare system that we have, kind of a non-system actually. I think that it's a for-profit system. People have to make money in this system. And as long as we have that kind of a system, I don't think we can get a long-term solution that works for everybody in this country, as so many other countries have national health, industrial nations like ours. And I think that it's really, really important that we consider that as a solution to some of these problems. And if you're impoverished, you're just trying to survive daily. And all the things that you want to present to people, they can't do it. They can't. They have to have a system that allows them prevention and allows them access. If you tell them they have high blood pressure and they can't afford the medication, what does that mean?
Right.
Okay.
No, agreed. I think, changing the paradigm to actually pay for prevention is key. I think we pay for the wrong things. Important things, but still, there's no incentive for prevention of disease in general for all hospitals. So all hospitals are, they focus on high paying procedures and so on and so forth, and that are important, yes, but the insurance companies, including Medicare, quite honestly, doesn't really reimburse for a lot of preventive services as much as they reimburse for other kind of more intensive therapies, which is, I think, is the wrong paradigm.
You look at many factors that are influencing cardiovascular disease. One thing I did not notice was anything about diet between green areas, red areas.
Right.
Can you talk about that a moment?
Yeah, absolutely. So remember that these studies were population-based. So it's not like we went and asked every single individual, right? Because it's a huge, we're talking about hundreds of millions of individuals throughout the United States. There are studies, though, not done by us, that looked into food security, for example, as a measure of the lack of access to healthy food around you, and the metric in the United States, and that has also been linked with redlining. One of the things that we're focusing on right now is looking at our redline neighborhood in Cleveland, where we can start to tease out some of the more critical and more granular questions that we want to ask and understand really the major drivers of this relationship. So we're going to be performing a study in East Cleveland to really understand from the residents not only how, whether they have access to things, but also what is the impact of the neighborhood that they live in, whether, what are the lived experiences, whether it's gunshot wounds and other things, and gunshots and violence, whether it's the noise, whether it's the, the smell, whatever it is that they have to give us in terms of subjective and objective measurements of the neighborhood. This is something that will be upcoming in the future.
I have a couple of online questions again. But this one is there a health insurance model that could best improve population health? And I just want to put a little plug in for the forum while we're talking about Medicare and insurance, et cetera. On February 26th, we are having a forum on Medicare and the effect of Medicare Advantage on it.
Yeah, thank you. I think it's not an easy task, because if there was a clear winning strategy for health insurance, that would be the only one that you would see. But it's not clear what is the best model of care, right? So you see countries where there is socialized medicine, like Canada or UK, for example, and we get patients from Canada all the time, because in order for you to see a specialist, it takes you 6 months, right? It takes you a year. And sometimes you have to jump through so many hurdles to actually get to see a person, a doctor or a provider that can actually help you with your issue. So there is a flip side to each kind of healthcare delivery model, and the focus on preventive care is important, but also there needs to be some access to specialists, because there are a lot of studies, for example, that showed that if you live in the United States and you have narrowing of the aortic valve, you can go and get your procedure in a week or two. In Canada, the wait time is about a year, right? So a lot of people die even before making it to the procedure. And while it's free of charge healthcare, but again, it's turning to be a little bit more hybrid model as they start to implement a lot of private practitioners and so on and so forth.
One more question. Is there a public education component to your project to provide health education to high school students with an eye towards changing health risk behaviors?
Yeah, that's an excellent question. This project is mainly for middle-aged individuals who live in public housing programs, but there are other components of other projects that we're working on. My colleagues are working on educating high school students, for example, for CPR training, right? Educating them on how to change the trajectory of their health. There is a lot of work that's ongoing right now in Cleveland and in specific fashion. But before we deploy things broadly using a lot of resources, sometimes it's important to measure and estimate in a small sample what is the impact of what we're doing, so that we can put a lot of resources into educating the individuals throughout the community.
Thank you, Dr. Al-Kindi. I would like to express my appreciation for the information you've given us today. It's been really terrific. Thank you. Next week's forum is going to be on censorship, muzzling the message and the messenger. The speakers will be Felton Thomas, the CEO of the Cleveland Public Library, Merrill Johnson, a representative on the Ohio Department of Education, and Owen Ganor, a high school student, and Maggie Nash, an author and educator, who will be the moderator. On February 26th, we're having a forum on Medicare privatization. J.B. Silvers from the Weatherhead School of Management will be the speaker at that forum. And on February 19th, we're having a forum on the Western Reserve Land Conservancy, and Alex Zika, the CEO of the Western Reserve Land Conservancy, will be the speaker at that time. We invite all of you, if you're interested, to attend our 10:15 service upstairs in the sanctuary or on our website. Today's service is very tied to the subject for this forum. Classism in Our Lives will be conducted by Suzanne Zilber and Valerie McFadden, members of our congregation. And to see what else is happening in our congregation, you can check our website at uucleveland.org. And again, thank you all for joining us this morning, and thank you, Dr. Al-Kindi.
Thank you so much.